Gears because we have had enough of roller coaster ride. So I will be taking up tough cases, what I come across in my clinical practice. So this is a child who has a extreme subluxation. So how the retina people wanted to do it, but I thought that I might give it a trial. So the first thing first is that what I do is the site I have to compartmentalize both the anterior and the posterior segment. So what I'm trying to do, before I do that, I'm dilating the pupil. So this pupil is being dilated in more than 180 degree, and now I'm trying to push in visco so that there is compartmentalization. Once that is done, the next part is how do I create a rhexis? Because rhexis creation is the most important part in the whole story. So I'm going to center around the center of the lens. I'm going to make it slightly smaller. So here I'm going to tell you what all wrong things I did, despite which I had even to go through. What would I have done if I was supposed to do it again? I would have used, this capsular hooks again, because you can use capsular hooks even with 1 millimeter of intact, rhexis ahead of you. But I continued, and to my delight, I was able to complete the rhexis. So now what I did was I used capsular hooks to act as artificial zonules, to give adequate support to the bag. I did hydrodissection. I thought it would not do. So what I did after trying that was that I went in for viscodissection, and I was able to separate the whole cortical mass from the bag. And once I was able to do that, I did, IA. I retracted the sleeve because I wanted to have two planes of irrigation and aspiration. Mind it, the IOP was 28 and I was using low fluidics to my advantage. So because as Vasavda et al. Has shown that with high fluidics, even an intact hyaloid face can be broken. No doubt in a child it is very difficult, but still low IOP did help in letting me accomplish of having a now stable chamber settings. Once that was achieved, what was next was that I had to use a CTR to my advantage. So CTR implantation is something which is done and which gives equatorial support, horizontal support. Since there was quite a bit of absence of zonules, so I would be, in addition to the CTR, I would be using CTS2. So the idea is to just put in the CTR, and once that was done, the bag had now to be fixed. So what had to be done was, so I took in the CTS, and I had already created a partial scleral flap because I wanted to, I didn't use a Hoffman's one. So I was positioning it rightly, and once I was able to position it, then I placed a partial sclerotomy. I railroaded it. The needle went through the other end, and you would find that I was able to push it through. So, this is something which really helps, because in these children you can really fix it to the sclera. Since it was a progressive one, I should have done it both the sides, double CTS usage, so that the back could be fixed permanently. Because it's a progressive ones, I'm railroading it. It is a non-edited one to show how I was able to do it. I go in again, and then I bend, approach the bag, go over it, and railroad it. So this is the way I was able to achieve it. So now once that is railroaded, I'll pull it out. So pulling it out is going to be easy as of now. So I just pull it out. Now I'm going to titrate it so that the IOL gets centered. And with this, I'm going to titrate it so that, the bag, the capsular rhexis gets centered. And once that is adequately centered, now the intraocular lens will go in and the surgery will be completed. I should have and I could have done double CTS implantation, Richard, what do you say about it?
Well, I was going to ask you that question, Red. Are you happy with those sutures long term? I mean, what suture are you using?
There is some degradation with these poly sutures. Gore-Tex should have been done ideally.
Yeah, I mean, the other alternative is to use something like 5-0 Proline with a modified Yamani approach, where you flange the suture inside the CTS and then bring it out of the eye and flange it there, which would give you something that was somewhat stronger than what you've got there.
And double, would you do?
Double, I think. Well, the other alternative would be to use a double Sione.
Yeah, absolutely. So this is another case, an adult this time, who has more than 180-degree subluxation. The plan was, what should be the site of insertion? A site of incision. It should be on an area which has intact zonules. Now again, compartmentalization by using a visco. Once that is done, Rex's initiation in the direction of the site where the zonules are absent. I'm moving ahead, trying to go around and complete the Rexes. At this point of time, I could have started using the capsular hooks, but I was lucky enough, I continued, and I was able to complete the Rexes. The Rexes has to be centered, not with the pupil, but the lens. Once the capsular hooks are there, they are acting as artificial zonules. Now I will start with phacoemulsification, but before doing that, I'm trying to put in the CTR. Nowadays, I am not using CTRs in the initial stages because at times it creates more trauma. So because capsular hooks do serve the purpose, and in such conditions, since it's a slightly old video, so I did go in with a CTR. Nowadays, spiral CTR has also come, wherein there is less stress to the zonules while you are implanting the CTR into the bag. So the trick is in these patients is that you have to go through the area where the zonules are intact to the area where the zonules are not there. Once that is done, the emulsification is started. The IOP is around 40, so I am doing chopping. And because of the artificial zonules, I would be able to rotate the nucleus because the bag, which was devoid of all these zonules by more than 180 degrees, have been taken care of by the capsular hooks. Now the emulsification is started, and you can find that if I am trying to rotate, I am not having many issues whatsoever. So now now comes the IA. The trick with IA is that you have to do tangential stripping, because at times when you do the stripping, you end up with a situation wherein it becomes very difficult to do IA. So tangential stripping of the cortex is the key in such situation, and you will find that I'm going tangentially and pulling it. This helps. So you can use tangential stripping of the IA in all patients wherein you feel there is zonulopathy. So that is one situation wherein you should use it. Once that is done, so I think I've already explained about the fixing it to the bag. So the pearls are triamcinolone injection, stable chamber settings, OVD compartmentalization, site of incision is very important, capsular hooks aided CCC, hydrodissection, viscodissection, biplanar IA, CTR, scleral fixation of the bag, IOL complex, bag IOL complex fixation. Richard, anything you would like to?
Yeah, I mean, I just think I would do it in a different order. I certainly would not have put the CTR in when you did, because you've got the capsule hooks there. You can put as many capsule hooks in as you like, and you'll make the bag completely stable. And it means that getting the cortex out will be that much simpler. The other thing, that if you're going to put the CTR in and you're going to get support, I would suggest maybe using the Malyugin modified Sione ring, which is much easier to put in the standard Sione ring, and then put a CTS on the other side.
Yeah, thank you. So this is another patient wherein the surgery is going on normally. There is no pressure whatsoever, and The patient was very happy with the first surgery, and she wanted to get the second surgery done. And suddenly she started having some bit of pain. And the moment I took it out, you can see that there's burping. The posterior capsule had become convex. I tried to push it in, and I realized that the eye is hard. I somehow was able to push in the intraocular lens, and you can find that the iris is coming out. So now this iris is coming out. Now the idea is, what will you do? Either it can be a fluid misdirection syndrome or a suprachoroidal hemorrhage. Most of us do not have any facility at that point of time to really make out whether there is any suprachoroidal hemorrhage or not. So what we do is, I asked the patient, I shifted the patient, got the fundus examination done, gave IV mannitol, and the patient was brought back. And this fluid misdirection syndrome, and you can find now that the IOP has come down and there is no iris which is coming out, and the surgery was completed without any problem whatsoever. There is another trick which can be done if you find out that there is no suprachoroidal hemorrhage. So you can do a pars plana vitrectomy to take out the fluid pocket, and that can easen out things. And this is courtesy Debashish Bhattacharjee. So the IOP had risen, and the IOL has started coming out. So he did the pars plana vitrectomy, and the pressure reduced, and the patient and the surgery was completed without any issue. So low fluidics is something which can be used in these patients, because that decreases the amount of fluid which will percolate through into the posterior segment. So low fluidics in these patients does help. So this is a routine cataract with patient having nuclear sclerosis grade 1. So the surgery has been started. It is continuing. The resident, the fellow is doing it. She's very happy with the surgery. And suddenly, she realizes, oblivious to what she was doing, she went in deep, and there was a PC punch. Now the question is, what next? Dr. Namrata, would you suggest, what would you do? Luckily, the resident was intelligent enough. She realized, she closed it up and sent it to us.
So I think first and foremost, before you take that probe out, you should put a viscoelastic agent which is dispersive like Viscoat, and then take the probe out. And then in this case, you can, I would still go ahead with the phaco after doing vitrectomy in the area of the punched out area. And then I think it is still possible to do it, because the cataract is not so hard also.
Yeah, it's NS2
It is a relatively softer cataract.
So
yes.
So what next was, either I convert, or as Dr. Namrata said, use IOL as a scaffold, or continue phacoemulsification. Well, the plan, what I had was that the CCC was intact. So there was no issue whatsoever. I would be using low IOP phacoemulsification to my advantage. I would not be rotating the intraocular lens, implant IOL if possible, and change to IOL scaffold if required. So the low IOP settings which I would be using would be around 18 to 22 18 is not possible, 20 to 22 millimeters for the physiological one, or I call the supraphysiological one, in which I use IOP between 23 to 34. So let's see, the patient was shifted to my OT. So low IOP was being used. I divided it. I knew that since it is a grade 2-1, I would be able to take care of it. The low fluidics gave me an advantage that there was less chance of the anterior hyaloid phase getting broken, number one. There was less infusion of fluid into the anterior chamber. The lens fragments would be floating in the anterior chamber. They would not be pushed behind, and there would be less chance of the anterior hyaloid phase being broken. Once that was done, I did not rotate it. I brought it forward and since the nucleus was relatively non-hard, I was able to continue phacoemulsification using low parameters, and the job was done. So once that was done, the next thing was, I move on. Then I did the dry aspiration after creating stable chamber settings. So I retracted the sleeve. I could have used a bimanual. This is the technique which has been shown by Bob Welch and James P. Gills of dry aspiration using the 25 gauge cannula. You will find that the size of the punch is the same as it was at the start and at the end of the surgery. I should have and I could have rounded it off and completed the posterior capsular axis. Nevertheless, I went ahead and did an optical capture. So this is another patient wherein there is an anterior segmentosity of a patient with VR surgery, and it showed that the patient had a posterior capsular punch. So I would be using calibrated incision to prevent any leakage, both the main port and the side port, oval rhexis, no hydrodissection, low IOP phacoemulsification, and the routine things which I showed in the last patient. The same settings I would be using. So I started with the surgery. An oval rhexis was created in this patient. Once the oval rhexis is created as has been shown by Kiranjit Singh, which gives the advantage of a large and a small rhexis, which allows optic capture if it has to be done. So I'm starting with the sculpting. The low IOP settings are being used. I chop it, and after chopping it, my main idea is to separate it into two nuclear fragments. Then I use try to do cross chop. No, I tried to pull it out, and I was able to pull it out in one go. So once that was done, so this was being done under low IOP settings, which afforded, non-pushing back, floating of the nuclear fragments, in the anterior segment, and I was able to complete the, emulsification with an open posterior capsule. So once that was done, you will see now what I do is I use the dry aspiration, and after using the dry aspiration, I put an IOL multi-piece IOL, and do an optic capture. So this was how it was managed with an open posterior capsule. So this is another highly demanding patient, coexisting astigmatism. Toric intraocular lens was planned, and there was a pre-existing posterior capsular defect. Surgery was started, and while doing the surgery, I realized that the patient had a PCR. So now what would you have done, Dr. Richard, at this point of time? There's a PCR at which I realized was there when I just completed my phacoemulsification.
It's a little bit difficult to see on the screen. How large was the rupture?
It's a typical posterior polar one, which is extended.
Okay. Yeah, I can see it now.
Yeah.
I mean, the thing about these posterior polar ruptures, they're actually pretty stable. And you can, if you're, when you've done a bit of vitrectomy, if the hyaloid has been dispersed, you can actually use those flaps, and you can put the IOL in the bag. It's not a problem. It's not like one where you've got a tear that you can't create as a posterior capsulotomy. But I put posterior chamber lenses into the bag with these. It's not a big issue.
Yeah. So what I did was, because I had been using low fluidics, I somehow was confident that I would be able to pull it in, which I was able to, because had I used higher fluidics, it would have extended back to the periphery and become a wraparound tear. So I just wrapped it around, and then I put a toric intraocular lens. So what I did was, after I placed it inside, I rotated it to the axis which I wanted to, and I flexed it in. The chamber has to be adequately deep, and then I flexed it in, and it went into the bag. Other side also, I flexed it in, and I was able to orient the toric intraocular lens the way I wanted to. I think there is paucity of time, and if Dr. Namrata.
Thank you very much. Rohit, can you just put this on? And I'll ask Namrata to shift that side. Just put on my things. Thank you very much, Rohit.